Okay, 601, we'll go ahead and get started. So here we are this is lecture number 5. This is the advanced cervical lecture. We're going to add quite a bit more into this piece. So at this stage in the program, you should have been through, unless there's been some scheduling issues, should have been through the first lab, and if you weren't doing any dry needling before, now you should be practicing those introductory techniques with your patients. Hopefully, as we start going through the advanced courses, then you'll start to get the information that you need to really start bundling these different needle locations together. At the end of this lecture, there will be probably 8. I'll know more when we get there. I think there's 8 specific protocols as well as 4 perineural protocols. So when we get there, hopefully you'll be able to take those and start applying those as well. But let's look at what we're going to talk through today. Some of this we will have already gone through. So here in cervical spine structures, the main things that we're really going to add here are the longissimus and iliocostalis cervices. These other issues, these other structures we added and we looked at when we did those 2 dry needling locations adjacent to the spinous process of C6 and T4. Longissimus cervicis and iliocostalis, we'll find that we'll do from a lateral approach. We're going to add in the suboccipitals and then the anterolateral cervical spine as well. There will bring in the SCM and the 3 scalenes. And then the scapulothoracic, we've already done the upper trapezius, but we're going to add in the levator scapulae. We'll move into the temporomandibular joint, the muscles of mastication, the masseter temporalis, the pterygoids, the anterior posterior digastric, and then the superior inferior joint capsule and the articular disc itself. Then we'll move over to the craniofacial region. And we won't needle this very frequently, but when we do, most common that I've worked with it is in Bell's palsy. It can be helpful in restoring and returning some of that motor function to those muscles of facial expression innervated by the facial nerve. So we'll look at those. And then we'll look at our diagnosis protocols, our suboccipital, our headache, our migraine, again, TMJ dysfunction, Bell's palsy, that general upper trap tension business that we get, any of the specific cervical, sorry, I had to make sure I was recording here, any of the cervical, just general cervical pain that we deal with. Then we'll look a little bit more at things a little closer down to the CT junction, the cervical thoracic junction. And then periodically we will see, it's more common in young people, infants and so forth, but you can also see torticollis in the adult patient as well. So that can always be appropriate for dry needling. And then we'll look at perineural protocols. We'll look at the greater occipital, the lesser occipital nerves, the greater auricular nerve, and then finally the facial nerve. So supporting evidence, I'm going to go out there and say that I'd use some supporting evidence for the cervical spine before. I did not add anything new into our advanced course. If there's something that you would like to know, want to look at some supporting evidence, feel free, send me a message, let me know. I'll pull some out. Just got a little behind and didn't throw anything else in there. So let's move into what I'm going to call for clinical decision-making, our 3D kinetic screen. So the 3D kinetic screen, or the 3KS, is a tool that's designed to examine complex movement patterns in the body to locate areas of asymmetry, movement dysfunction, and pain. It is patterned after the functional movement screen, which was created by Gray Cook, which is designed for athletes. The 3KS, it's actually appropriate for all age groups and in all ambulatory levels of activity. So the functional movement screen that Gray Cook put together, great for athletes. It's a wonderful tool to look at movement dysfunction, asymmetry in movement. The idea is you can take that, you can score that movement. And then you can apply a treatment, come back, test it again, and you should see an objective improvement in that functional movement score. I've changed the movements that I look at, especially when we're dealing with dry needling approach. And so the 3KS is made up of a battery of 11 movements, and they are cervical linear motion, cervical diagonal rotation, trunk rotation, and those three, in a moment we'll see, are the three that apply specifically to the cervical spine. Further down the chain, we'll look at lumbar linear motion, lumbar diagonal rotation, figure 4 sitting, the shoulder posterior external and internal rotation. We'll look at a single leg stance. We'll look at the sit to stand test. We'll look at a quarter lunge, and then we'll look at heel and toe walking. But for the purposes of the advanced cervical lecture here, the 3KS for the cervical spine includes our cervical linear motion, our cervical diagonal rotation, and our trunk rotation. In reality, the entire screen should be performed and scored to completion to determine the effects of movement in one body region on the other movement systems. And at the conclusion of this entire course, you'll have all the elements in place to perform the entire 3KS 3D kinetic screen to identify painful and abnormal movement patterns, which can be treated and addressed through dry needling. But these are the three that we'll look at for the cervical piece. At the end, if you haven't looked ahead, I am going to have you, for your homework after this lecture, is to perform this, and then either you perform it and self-analyze it, or you can video someone else performing this, and then you can analyze their movements, whichever you want to do. I happen to perform it myself, and will analyze mine in just a moment. So before we get this moving, our cervical linear motion is just going to be a flexion and extension. We're going to perform 5 repetitions, and then we're going to move to our diagonal rotation, which is going to be looking up away over the left shoulder and then down past the right elbow. We'll do that 5 repetitions, and then we'll reverse that up over the right shoulder and then down past the left elbow. Again, repeating that 5 repetitions, and then we'll do just a simple hands on chest, a trunk rotation. Again, 5 repetitions are what we're going to look at. But me performing it looks like this. So I will say that I do have some cervical issues. I have a fracture of the left clavicle with ORIF. I've had surgery on the right shoulder, and so you may see some asymmetries. Matter of fact, let me come back. So you can see I'm carrying my right shoulder, it's depressed. My left, I tend to keep that elevated. I can tell you, as I was doing these motions, as I start doing my cervical diagonal rotation on my right side, right at the base of the neck, right next to the upper trap, I did have pain and tightness in all of the motions in that area. Nothing else really created any issues. I do have a light limitation in my movement, but all in all, that was the biggest thing that I noticed. Other than how I carry my right shoulder a little bit higher than my left. As I look at my trunk rotation, as I rotate to the left there, I evaluate how far my shoulders are going all the way around. I definitely have a little bit more rotation as I'm rotating to the left than I do to the right. What does that mean for me? I don't know. And so now we'll look at it in this plane. Again, I could have a little bit more cervical extension. It could be a little bit better. Again, as I perform this motion right here, say at C7, T1, at that levator junction, I did have a significant amount of discomfort. Say it was a a 3 out of a 10. As soon as I stopped, it went away. And this is information that you wanted to get from your patient whenever you're having them run through these little tests is what, number one, what asymmetries are you seeing? And number two, what sort of complaint are they demonstrating? What are they telling you they're feeling during this process? Again, I'm getting a little bit better rotation to the left than I do to the right. Equally, I'll tell you that that video was shot while we were staying in a hotel, and my sleep wasn't as good, so maybe I was dealing with some thoracic tightness. Maybe there were some other things going on. Hard to say, but being a functional movement screen, it really can tell us a little bit more about maybe where this problem is. What do we need to focus? What do we need to dial in on? So those are the 3 pieces of the 3KS for the cervical spine. Okay, so let's move into our posterior cervical spine. Again, we've already talked about a lot of this except for longissimus and iliocostalis surfaces. So I'm going to come on down to those. And we will. Actually, we've got a 3D anatomy piece before we get to it. Longissimus surfaces, its origin. It arises by the long, thin tendons from the summits of the transverse process of the thoracic vertebra 1 to 5, and it inserts by the similar tendons into the posterior tubercles of the transverse processes of cervical vertebra 2 through 6. And so the question is, and well, let's look at iliocostalis as well. Its origin, the angles of the 3rd, 4th, 5th, and 6th ribs, and it inserts into the posterior tubercles of the transverse processes of the 4th, 5th, and 6th cervical vertebra. So earlier we were, let me come back, talking about, or I say earlier, in the introductory lectures, we talked about how we were selecting C6 to needle into the majority of our structures. We made one alteration. We came down and needled off of the spinous process of T4. Well, as you can tell, neither of those needle locations would have let us gain access to iliocostalis or longissimus. You'll see in a bit that that's why we go to the lateral articular pillar in order to needle those structures. How often are they involved clinically? Probably not that frequently. However, we do want to be able to interface with those, and so there is a nice location where we can get to that. Okay, let's come on down and let's look at our 3D anatomy. So let's look at the three-dimensional anatomy of the cervical, the posterior cervical spine. Now, in the earlier lectures, in the introductory information, I think it was lecture 2, we went ahead and talked about most of the three-dimensional structures in the posterior cervical spine. What we did not include were some structures here on the lateral. So here what we're talking about is the longissimus, let's see here, kill that. All right, longissimus coli or cervicis, and then the iliocostalis cervicis or coli. And we didn't deal with those previously. So you see there, so for iliocostalis, origin is off the angle of the 3rd to the 6th rib. So its origin is down low on the rib cage as well as longissimus. Let me bring that one up. So longissimus, again, here the transverse origin is the transverse processes of T1 through T6. So we've got some distal thoracic origin for these muscles, but the interesting part is where they attach where they insert. So as I move here, I want to take a really close look. So as you can see, they attach to the articular pillar. So if we were to try to use dry needling for these small muscles on the thoracic rib cage, it would be rather challenging, and because of the location, probably not recommended due to the location of the danger zones here into the lung field. But as we look, if we take an approach targeted towards the articular pillar on the lateral side, makes that quite a bit easier to draw a needle to. And so we'll include that in a lateral approach where we'll also include the posterior and the middle scalenes. So we're going to, similar to how we had at C6, spinous process of C6, we covered a lot of the musculature here, similar to spinous process of T4. In that case, we were able to get the distal fibers of, if I can get it to pop up, of the splenius cervicis here. Now we'll actually be able to, in theory, be able to needle through that muscular tissue on the lateral ridge of the cervical spine. So that is our three-dimensional anatomy of posterior cervical spine, specific to longissimus and iliocostalis cervicis, that further erector spinae group. So, okay, so the surface anatomy palpation lab, I'm going to move in. We had talked about this in the introductory piece. Here is where we really start to get gets very relevant in our ability to identify this lateral articular pillar. We're going to see in a moment that we will needle onto that. Why is that an issue? Well, quite honestly, because our vertebral artery runs right through just anterior to that articular pillar. As well, we see the brachial plexus exiting in this area as well. So proper identification is extremely important. I always encourage, if you're uncomfortable with your palpation of this structure, then you don't need to needle there. Because if you can't be certain of where your needle is being placed and where it's going, then you need to stay away from it. Patient safety is always first. And so we do look here at the different structures we've identified: the hyoid, the thyroid V-notch, the thyroid cartilage, the cricoid cartilage. So let's move down. I will have this. I do want to cover this one more time. So we'll start by taking a look at our surface anatomy of the cervical spine. We'll start with some anterior structures first to give us a point of reference for identifying posterior structures. And so let me bring up my pen. The structures anteriorly that we'll look at first will be the hyoid bone. Second, we're going to look at the V-notch of the thyroid cartilage. Thirdly, we'll look at the smooth lateral surface of that thyroid cartilage. We'll then look at the cricoid cartilage. And then lastly, the sternal notch further distally. So these would be our anterior structures. Okay, so let me clear that and let's look at it from a lateral aspect. So how these are going to correlate to our structures posteriorly. The reference is going to be a little bit from a anterior inferior to a superior posterior angulation, simply because of the cervical lordosis that we have. But if you place your hand underneath the mandible, underneath the jaw, and let me drop that down just a little so we can see everything here. Okay, so there we are. So we look at hands underneath the mandible. You can have your subject swallow. You'll feel that hyoid bone move. That's going to have a direct correlation with the spinous process of C3. My line is not exactly straight, so let's try that again. Here we go. There we go. So there we have C3. The V-notch of the thyroid cartilage, and these are all palpable, you can palpate them on yourself, is going to orient to C4. The smooth surface of the thyroid cartilage itself is then going to align with C5, and then further distally, and it sits right about here as a smaller, harder structure, the cricoid cartilage, and that is going to orient to spinous process of C6. We drop down a little further distally. Again, the sternal notch sitting right here at the junction at the upper end of the sternum, the manubrium, where that's orientation will be relative to the spinous process of T2. Okay, so let's look at our surface anatomy from a lateral aspect. Some structures we'll be interested in here. Number one will be the mastoid process, just inferior to the ear. We can palpate that. Excuse me. Just inferior to that will be the transverse process of C1. Another structure of importance, especially as we get later into our course, will be the lateral arch, our laminar arch. And so that's on most people that's fairly easily palpable. It can be tender, especially if someone is having some posterior lateral symptoms, but that is going to be an important landmark for us to discover a little bit later. So let's move from here. Let me clear that, and we will move posteriorly now, and let's evaluate some of our important landmarks here. So let's start first with the external occipital protuberance, easily palpable in this area. There are then going to be three lines of importance, really two, but there's three here, so we'll discuss all of them. First is the supreme nuchal line. Adjacent to the external occipital protuberance will be the superior occipital protuberance, and then further distally and much deeper will be the inferior nuchal line. So supreme, superior, inferior nuchal lines. Let's talk about the spinous processes posteriorly. C1, rather difficult to palpate if it can be palpated at all. Most commonly, C2 is our first spinous process that we can palpate. We can follow by palpating in between each spinous process and the interspinous space to find each of the subsequent spinous process. Of importance, we get down to C5, C6, C7, T1. Then we want to know, okay, well, how do I know if I'm on here? So the easiest way between C6 and C7, a person that's 40 years of age approximately or younger, when you extend the neck, C6 is going to move anteriorly, and then as you extend, it's going to come back to a normal position. C6 does tend to sit a little bit more anterior than C7 to begin with, but in a nice seated position with that extension, C6 will move forward. C7 tends to be the last of the vertebra that will have some rotation in it, and so if you place your fingers in between the interspinous space between C7 and T1 here, and then do some rotation, you should be able to feel the differentiation between the spinous process of 7 and 1 as well. As you've identified T1, you can move out laterally and palpate the transverse process of T1. If you move a little bit further laterally, then you feel the drop-off. That drop-off indicates the transition from the vertebra itself into the first rib. So that's the vertebral and rib junction interface. So that's rib 1. Likewise, if you proceed down into the thoracic spine, you'll notice that as well. If we've identified T1, we can look at the sternal notch anteriorly, and we know that is T2 as a reference spot. So we'll start by... Okay, and let's go ahead and look. We've identified that, but let's look at it on our subject.
Posterior cervical spine musculature, we can get a good idea of where we're dealing with posteriorly by our anterior structures. I don't necessarily do this with every patient, but it's a good frame of reference for us to utilize. So what we'll look at is our hyoid bone, our V-neck our V-notch of the thyroid cartilage, the smooth side surfaces of the thyroid cartilage, then the cricoid cartilage, and then lastly the sternal notch. So if you come in with your patient.
So I'm going to pause right here. If you've been through the lab, and you should have, then we've already been through on your subject, your identifying of these marks. As we get into the more advanced structures, most definitely this lateral articular pillar, again, is critical to be able to locate that. We should be fairly proficient in identifying our posterior spinous processes, getting to T1 and on down into the thoracic spine. But the key here is making sure that we definitely are able to palpate from the transverse process of T1 and then following that articular pillar all the way down.
On our surface.
Okay, so let's look at our cervical spine treatment. We have already been through in the introductory portion the spinous process of C6 and then further down at C7. And definitely that's a critical part. 1 finger breadth lateral to the spinous process of both locations. Again, these can be carried from C2 all the way down into the sacrum, quite honestly, to dry needle a lot of this paraspinal musculature, with our ultimate goal being the multifidus. Again, these 2 locations being identified for the cervical spine to catch a lot of that structure that's really starting to take an oblique angle away from midline. But we've done that in the introductory piece. I'm not going to go through it again here. Actually, I mean, if we're here, let's see if I can get to it. So very simply, about 15 to 20 degrees inferiorly and medially, posterior to anterior. Okay, we drop down the spinous process of T4. Here we're going to get splenius cervicis. Again, as we get more superior, more cranial, it does have a lateral veer away from midline, so we have to get it further distally. T4 is a great location to do that. And as we can see in the picture, I'm just a finger breadth away from midline, and I'm going about 15 to 20 degrees inferior and medial. And we'll play that, and again, 1 finger breadth away from the spinous process, 15 degrees medial and inferior. Okay. So the other muscle videos are in the student portal, at least in one place. Here we want to move on to, so we didn't include, we're going to get to those in the lateral piece. Let's move up into the suboccipital region next. And look at these muscles: Obliquus capitis inferior and superior, and Rectus capitis posterior major and minor. Obliquus capitis inferior, I think I've got this all in our 3D anatomy section, so let me move down and get into that to make sure we do. Yes. Okay, so 3D anatomy of the suboccipital muscles. 4 on each side. Here we'll look at the Obliquus capitis superior, the Obliquus capitis inferior, those being more on the lateral aspect. And then medially we have Rectus capitis posterior major and Rectus capitis posterior minor. So let's look at some of the 3-dimensional aspects of these. You'll notice that they all have very similar, there's a lot of similarity in origin and attachment of these small little muscles. You can see on the spinous process of C2, we have both rectus capitis posterior major and oblique inferior, both attached to that. And then there's a common attachment of Obliquus capitis inferior and Obliquus capitis superior on the transverse process of C1. And then it seems So then we have a very common line of attachment at the inferior nuchal line on the occiput. So one of the more challenging of the suboccipitals is, in reference to dry needling, is, let me bring that up, is the rectus capitis posterior minor. And goes without saying, the issue we get concerned about here is the foramen magnum. Traditionally, with dry needling, the approach is to take a posterior caudal to a posterior inferior caudal to a superior anterior approach. Well, the problem there is, again, in this general area, we can see there is the foramen magnum. And if we really want to make a good effort at hitting, especially minor, rectus capitis posterior minor, then we do have to orient our needle angulation to the foramen magnum. The problem is, well, we don't want to do that. The bigger issue is if we take too much caution in this posterior approach, then we find that we will probably more than likely land in between superior nuchal and inferior in this area, which means that we're not really hitting our target structures. So because of that, I've developed a novel approach to needling to stay away from the foramen magnum, from the brain stem, the spinal cord as it's coming inferiorly, but still making sure that we can get to those structures themselves with a slight posterior angulation. So the suboccipital muscles, they become a technical dry needling location to make sure that we do hit these, but that we also stay definitely away from our areas of concern. Okay. So moving to the treatment lab. So for obliquus capitis inferior, a patient is going to be in the prone position. And I should talk through this in my videos. So anyway, I want to get to it. So here we're going to palpate the spinous process of C2 and then the transverse process of C1. Here we're going to needle in a slightly inferior angle, maybe just 15 degrees at the midpoint between those two landmarks, in a perpendicular angle relative to your landmark. So perpendicular to the skin, basically at that point in midway between spinous process of 2 and the transverse process of 1. In the suboccipital region, the obliquus capitis inferior. Patient's going to be in the prone position. Needle length is only going to be about 2 centimeters. Backdrop here will be the lamina of C2 or none. Precautions, greater, lesser occipital nerve, the third occipital nerve, second cervical nerve, the spinal column, and the vertebral artery. Here we're going to palpate the spinous process of C2 and the transverse process of C1. At a midpoint between the two landmarks, we're going to needle in a slightly inferior angle, about 15 degrees, in a perpendicular angle relative to your palpated landmarks, which will be slightly lateral to medial onto the lamina of C2. Okay, so for obliquus capitis superior, well, we'll get here and we'll let that do its talking, but we're going to palpate the anterior inferior aspect of the mastoid process. So we're just going to drop below the ear, we're going to palpate for that location, and then we're going to move 2 finger breadths posterior to locate our needle location. And here we're going to needle lateral to medial in a transverse plane, no more than 2 centimeters. If we go further than 2 centimeters, then we do run the potential of, say, if we grab a 3-4 centimeter needle, then we do run the potential, the potential of getting close to that brainstem, getting close to that foramen magnum. So very much, absolutely, 2 centimeters is our the extent of our length of our needle here. That will get us into that tissue. It is it's a very lateral muscle. But if we go too far, then we may get into some business we don't need to be in. For the obliquus capitis superior, patients again are going to be in the prone position. Needle depth is going to be about 2 centimeters. Backdrop here is going to be the occipital bone. Precautions: the occipital artery, vertebral artery, first cervical nerve, and the suboccipital nerve. Here, the patient will be in the prone or the side-lying position, and needle length will be 2 centimeters. We'll palpate the anterior inferior aspect of the mastoid process. We're going to move 2 finger breadths posterior to locate our needle location. From there, we're going to needle lateral to medial in a transverse plane no more than 2 centimeters. Okay, now moving on to rectus, capitis, posterior major, and minor. We'll needle both of these as with one needle. So here we're going to palpate the anterior inferior aspect of the mastoid process. So similar to what we just did, and then we're going to also look for the posterior apex of the skull. And what we're going to do is find a midpoint between those two. So in a transverse plane, the needle placement will be at a midpoint of the intersection of this anterior point and the posterior. From here, and that'll be our needle location. We're going to needle lateral to medial, slightly posterior. So we're going to start here, then we're going to veer towards the posterior, away from the foramen magnum here. So a little posterior, maybe 15, 20 degrees. Here we're going to needle, we'll need a 3 centimeter needle, but not more than 4 centimeters. Again, we do not want to needle into a frontal plane or anteriorly. So definitely, I would rather veer a little too far posterior and not hit our landmark than to accidentally needle towards the anterior aspect. So again, this is another one of those that if you are uncomfortable, if you're not 100% certain of your technique, you do not need to do this one. But this is a great alternative method to needle rec cap, posterior major and minor. Capitis posterior major and minor, CSO 3 and 4, will palpate the anterior inferior aspect of the mastoid process and the posterior apex of the skull. In a transverse plane, needle placement will be at a midpoint of the intersection of the anterior aspect of the mastoid process and the inferior point where the posterior line intersects. Needle lateral to medial, slightly posterior, 3 to not more than 4 centimeters. Caution to not needle in a frontal plane or anteriorly. Again, needle length will be 3 to less than 4 centimeters. And I'm going to have to go find that video. So I don't have the video in here. Let me see. I have placed that video elsewhere. So I will make that video available on the student portal. The one that I have here is specific just to RetCap posterior major, which I want to do away with. It can be identified, and basically its process is to move away from the spinous process of C2, just one finger breadth, and then needle a little bit away from medial, a little lateral towards the inferior nuchal line. The other needling approach covers both of those. So I will provide this one, which we'll see here momentarily, but I'll provide the other that addresses both major and minor in the student portal for your access. The rectus capitis posterior major. Again, I'm going to be in the prone position with a needle length of about 2 centimeters. Backdrop is going to be the inferior nuchal line of the occiput. Precautions: the third occipital nerve, the greater occipital nerve, suboccipital nerve, first cervical nerve, the foramen magnum, and the vertebral artery. At 1 finger breadth lateral to the spinous process of C2, we're going to needle cranially towards the inferior nuchal line in a 20 to 30 degree superior angulation, posterior to anterior with the occiput as a backdrop. Caution not to needle medially. So for the posterior major, this one is absolutely a good approach to take. It just doesn't let you get to the posterior minor in a safe approach. So find C2, 1 finger breadth lateral, needle placement location, and then slightly lateral with our needle advancement towards the inferior nuchal line. Okay. So we'll move on to the anterolateral muscles. Here we'll look at the sternocleidomastoid, anterior, and then middle and posterior scalenes. The SCM, its origin, and actually let's go down to the discussion with our 3D anatomy application to look at these structures. So let's look at the 3D anatomy of the lateral, posterolateral aspect of the cervical spine. Here we're talking about all 3 of the scalenes, posterior, middle, anterior, and then the sternocleidomastoid muscle. So starting with the SCM first, obviously it's got its insertion. Actually, let's talk with the origin first. This is the sternal head, and so obviously the sternal head, origin anterior surface of the manubrium of the sternum. For the clavicular head, obviously it'll be on the middle. It's about the middle third of the clavicle itself. It inserts into the mastoid process of the temporal bone. It actually has a fairly large footprint as you look around there from the mastoid process on further into the superior nuchal line. It's again a mastoid process and into the superior nuchal line of the occipital bone, with its action being flexing and laterally. It flexes and laterally flexes the neck, and then rotates the head. Its innervation is through the spinal accessory nerve, cranial nerve 11. I will fade that because I want to look a little bit. Actually, let me hide that. We'll take a look now at the scalenes. Scalenes important because of their location. Anytime we're dealing with rotator cuff issues, any radiating pain from the cervical spine out towards the shoulder, get concerned about the brachial plexus as it exits over the first rib underneath the clavicle, and the role that the scalenes has on that. So let's start with the posterior scalene first, and let me kind of rotate and zoom in on that. There we go. So the origin here, the posterior tubercles of the transverse processes of C4, 5, and 6. And its insertion is the external surface of the second rib. Here its action is laterally flexing the neck and then elevating the second rib. And its innervation is the anterior rami of the 4th to 6th cervical nerve, C4 through 6. We move and look at the middle scalene. So here, let me rotate. Let me fade the posterior. There we go. So we take a little bit better look at the middle scalene. Here, its origin, the transverse processes of C2 all the way to C7. Inserts into the superior surface of the first rib, and then its action is laterally flexing the neck and elevating the first rib. So since we're here, I do want to look at, let's see. I can bring in, nope, wrong thing. Here we go. Do want to bring in the brachial plexus. Let's bring that down a little bit. So between the middle scalene and then the anterior scalene, we have the exit of the brachial plexus. And so just a note for self. The middle scalene, probably the most prominent with its footprint, going a little bit more superior and inferior, and with its proximity to the brachial plexus as it's wrapping around, as it's heading laterally. But finally, the anterior scalene. Let me drop a little bit. So on the anterior scalene, its origin is the anterior tubercles of the transverse processes of C3, 4, 5, and 6. We also have insertion, the scalene tubercle of the first rib. So there, and then action again, it flexes, rotates, laterally flexes the neck, and it elevates the first rib. Again, it's innervated C4 through 6. So we see several locations of relevance here. I'm going to unfade that with the posterior scalenes attaching more posteriorly. We get to middle. We see the middle attaching more on the lateral aspect of the articular pillar, and then the anterior being more on the anterior aspect. So that would be the scalenes and the SCM, that posterolateral cervical group. So let's look at so let's look into our treatment here for SCM. Quite honestly, will be supine. We could be side lying if you wanted to. If your supine head's going to slightly rotate the contralateral side. There's no backdrop. It's about a 3 centimeter needle. We're going to lift that SCM up and away from the neck so we can avoid that external jugular vein. But let's get to the video there. For the sternocleidomastoid, the position of the patient is going to be supine with the head rotated slightly to the contralateral side. Needle length will be about 3 centimeters. There is no backdrop. Precaution here again, internal, external jugular veins. We're going to use a pincher grip, and we're going to grab the clavicular and the sternal heads of the SCM. We're going to pull it slightly away from and lateral to the neck. We're going to needle perpendicular to the fibers of the SCM in a medial to lateral, anterior to posterior direction to avoid the neurovascular structures. So go ahead and lift your head up again right there, and then relax. Okay, then we'll look at our lateral location on the articular pillar itself. Here this is where we'll get into the longissimus and the iliocostalis surfaces, but we'll also take advantage of this to get into our middle and posterior scalene. A lot of structures posteriorly that and more inferiorly that we just don't want to get into So we can take our lateral approach and get into our scalene, especially our middle scalene, which probably is more symptomatic than our posterior. But with a little anterior to posterior angulation, we can get into both of those there. So let's move to it here. Again, volume will be corrected in the student portal. For the longissimus cervicis, the iliocostalis cervicis, the middle and posterior scalene. Patient's going to be positioned in the sideline position. Knee length is going to be only about 2 centimeters. The backdrop here is going to be the articular pillar of C4 and C5. So precautions here, the brachial plexus, the vertebral artery, common carotid artery, the external internal jugular vein. For this, we're going to palpate midway between the clavicle and the mandible for the articular pillar. You should be able to differentiate between the pillar and the transverse process, which will sit more anterior. We're going to note the anterior and posterior drop-off. We're going to needle at C4 or C5, direct perpendicular to the articular pillar, lateral to medial with a 10 to 15 degree anterior to posterior angulation to avoid the brachial plexus and the vascular structures. Okay, then on to the anterior scalene. I have clinically needled the anterior scalene a handful of times. It is a technically challenging dry needling location, quite honestly, because we have to split internal, external jugular veins. Traditionally, it is that middle scalene that provides us our greatest amount of symptomology, but this is a technically safe way to needle anterior scalene if you can't seem to get it to respond to more traditional approaches of therapy. So here we're going to use the second and the third fingers to pull the clavicular border of the SCM medially about 1 finger breadth. So we're just going to pull that medially. We're going to divide the SCM then into thirds, and at the superior margin of the distal third, so right about here, at the lateral SCM border, we're going to needle in a partially medial angulation about 15 degrees to enter the target muscle, bisecting the jugular veins. Again, a caution here to avoid excessive depth due to the neurovascular structures. Again, if you can needle, if you can perform a manual therapy, absolutely, probably a wiser choice. A safe location as long as you're 100% certain about your location. This actually may be one that a dry needling with ultrasound may be more appropriate. It can be done without. However, you want to be technically accurate. For the anterior scalene, position is going to be supine with the head rotated slightly contralateral. Needle depth is only going to be 2 centimeters, less than 3 centimeters. There is no backdrop here. Precautions, important internal and external jugular veins, the common carotid artery, the brachial plexus, and the vagal nerve. We're going to use the second and third fingers. We're going to pull the clavicular border of the sternocleidomastoid medially about 1 finger breadth. We're going to divide the SCM into thirds, and at the superior margin of the distal third, at the lateral SCM border, we're going to needle in a partially medial angulation about 15 degrees to enter the target muscle, bisecting the jugular veins. Caution to avoid excessive depth due to the neurovascular structures. And then let's move into the anterolateral muscles here, upper trapezius, and then finally the levator scap. We'll have already looked at the upper trapezius, but I think I have a video here for that. A levator scap, a very good bread and butter. Again, when we looked at the 3KS that I performed on myself, I historically have some levator issues that I deal with on that right side. Again, bread and butter dry needling for almost anything in the cervical thoracic, scapulothoracic region. Okay, we're sharing here. All right, so the 3D anatomy of the posterior scapulothoracic region. Here, main thing we're going to add is the levator scapulae into what we're looking at. So let's highlight that and take a quick look at origins to the transverse process of C1-2 and the posterior tubercles of the transverse processes of C3 and C4. So we've got 4 locations of origin and inserts into the superior angle of the scapula, superior to the spine of the scapula. And so very common muscle structure that we see with any sort of dysfunction in that cervical thoracic, scapulothoracic, that shoulder, neck series of problems that we deal with. But let me fade upper trap out of the way. And so it gets very technical to make sure that we needle into the levator without entering into the lung field. So it can be challenging at times to isolate that superior angle of the scapula. Could be that we need to go hand behind back, but we do need to isolate that very frequently with anything in this area. And so that's a key part to cervical dry needling. Okay, we're sharing. Okay, so let's look at the treatment piece there, upper trap. Again, midway between the acromion and the base of the neck. Basically, we're going to find that tendermost aspect there and needle there. We can look at that piece. I'm going to advance that a little bit.
Needle length here is going to be position. Needle length here is going to be 40 to 60 millimeters. There is no backdrop. We're going to palpate for the thickest aspect of the muscle belly. We're going to grasp the muscle between the thumb posteriorly and the fingers anteriorly, at least 1 thumb breadth above the supraclavicular margin to avoid the apex of the lung. We're going to insert the needle into the muscle in a posterior to anterior trajectory using the fingers opposite the insertion point as a guide to determine needle depth.
Okay, so then let's look at levator scap. Very frequently, so right now we're needling everything in the prone position for these structures. As you get comfortable with the needling, especially after you've had your first session and you know the patient's response to dry needling, going to make sure that they're not going to have some sort of a vagal response. If you have them then possibly in a seated position. Either way, you're going to be able to hit the traps in the levator at the same time, same location. I'm going to teach you here to when needling the levator, always go from a medial inferior, threading through that levator scap to go more superior anterior. As you get a little bit more comfortable with identifying that superior angle, then you can go the opposite direction. But I feel like this is an easier place to identify that, especially if you're got the hand in the hammerlock or hand behind back position.
For the levator scapula, scapulae. The patient is in the prone position, hand behind back. Knee length is about 3 centimeters. There is no backdrop. With the patient's hand behind the back, we're going to use that pincher grab to grasp the musculature at the superior angle of the scapula. We're going to needle through the attachment onto the scapula from an inferior medial to a superior lateral direction along the plane of the rib cage, using your fingers as a backdrop.
Okay, so from there, let's move on to the temporomandibular joint. So anytime we start to talk about the sensitive areas, the face, the hands, and the feet, people do tend to cringe a little bit. And I mean, honestly, it's not the most happy thing in the world, but for a person that's dealing with temporomandibular joint dysfunction, the relief that we can provide through dry needling these structures can be significant. So let's jump right in. The superficial masseter. Here our origin is the zygomatic arch, and it inserts into the angle in the ramus of the mandible. It's innervated by the masseteric nerve, and its action is elevation, adduction, and protrusion of the mandible. We look at the deep masseter again. Its origin is the zygomatic arch of the temporalis. And so we'll see that drops right there. A little bit later, we're going to talk about the pterygoids, and we're going to needle in for one of the pterygoids right through this zygomatic arch to get to that muscle. So when we do that, obviously, we're going to catch deep masseter as well as superficial masseter as well. Anyway, it inserts into the angle of the mandible, and in here, its innervation is mandibular branch of the trigeminal nerve, and it elevates or closes the jaw. The temporalis, it has a large footprint for its origin, the temporal fossa of the temporalis and the sphenoid, and then it inserts into the coronoid process of the mandible. So a big muscle coming right over here. So you can tell that temporalis as well as the masseter, big part of somebody that has a clenching problem. Three really nice muscles. We can dry needle those things, get a good release, and provide some really positive improvement. We look at the lateral pterygoid, the two heads, the superior and inferior. It inserts into the joint capsule of the condylar process. It's also innervated by trigeminal nerve. This is the only muscle of the masticators that will protrude the jaw. So I'll actually pull it forward. Later we talk about exercises to do with TMJ, TMD problems, and protrusion is definitely one, and the lateral pterygoid is responsible. We look at the medial pterygoid, its origin, medial surface of the lateral pterygoid line. It inserts into the medial aspect of the angle of the mandible so the mandible is actually hidden here. It comes off of the lateral pterygoid plate on the jaw, on the skull itself, but it attaches down onto the mandible. So you'll see that we take a posterior approach to needle into this behind the jawline. And again, its action is closing the jaw. Anterior and posterior digastric, they are involved. They are muscles of mastication, so we do include them. You can tell they're fairly small, probably play a much smaller role in the event of pain dysfunction. We want to be able to needle those both off of the jaw itself from an inferior approach to anterior to the mastoid process. So we'll run through 3D anatomy of the muscles and structures of the temporomandibular joint. The three primary that we'll deal with will be the superficial and deep masseter, and then the temporalis. But let's look at, let me kill that. Let's look at the superficial masseter first. Here we'll see, let me zoom in. So its origin is the inferior aspect of the zygomatic arch. So that's very palpable. And then it inserts into the lateral aspect of the ramus of the mandible. So they're at that angle, mandibular angle, if you will. And its action is elevating the mandible, and it assists in protraction of the mandible. So it's got a little movement there. Innervation, the masseteric nerve. It's a branch of the mandibular nerve. So let's actually hide that. Whoop. I have to undo that to see if I can just fade that. Okay, here we go. So look on the other side. We'll see the deep part of the masseter. You can tell it's got a very similar footprint. Inferior aspect of the zygomatic arch, a little bit more posterior than the superficial branch, or the superficial part. Its insertion is the lateral aspect of the coronoid process in the ramus of the mandible. So it's, if we can get all the way around, that's kind of hard. So as you can see, it sits a little bit more cranial to the on the mandible itself. So we'll find that we can do some needling. The superficial masseter here, and then for the deep, we have to come up a little bit more cranial to make sure that we get and differentiate those two fibers. So let's come back and to this side. Let's go ahead and hide that now. So that'll bring us to the temporalis. Here, our origin is the temporal fossa and the temporal fascia itself. The insertion is into the coronoid process and the ramus of the mandible. And so it does extend down a little bit, but one of the bigger muscles we see dealing with clenching and so forth, temporalis, definitely a big role there. You can see with its function how it will cause the mandible, the jaw, to actually pivot through the temporomandibular joint itself. So let's go ahead and take temporalis out, and that'll give us a little bit better look for our deeper structures. Just so that we get it out of the way, let's look at the digastric, the anterior and posterior. The posterior belly of the digastric, its origin is onto the mastoid notch of the temporal bone. It attaches through this pulley, this sleeve of the hyoid bone, to then come around to the anterior belly, which it attaches to the digastric fossa of the mandible. So just below the mandible, the chin right there. There is definitely a smaller muscle, but because of their action that depresses the mandible, elevates the hyoid bone, they do play a role in the TMJ. So I do like to include those as potential causative structures. So we'll look a little bit further. Let's look at the inferior head, the lateral pterygoid. So we have inferior and the superior head. So this comprises the pterygoid. Though they are, we can needle these structures. Basically, we'll go in through this foramen created by the mandible and the zygomatic arch. For that, we come down a little bit lower, and for the deep head of the medial pterygoid, it can be needled from a superior aspect. I find that it's much easier, much safer to just come at it from the posterior aspect off of that angle of the mandible, and you've got a lot more surface area that you can needle into right there. We get a little bit more confined to the temporomandibular joint itself. We've got superior anterior joint capsule, anterior superior. We also have a posterior inferior joint capsule that can come into play. So in between that, let me get right back out. Then we also have the articular surfaces, but in between those, then we have the disc of the temporomandibular joint. So a lot of soft tissue in there. For us, we can needle into that articular disc, into the joint capsular anteriorly and posteriorly. Probably where we see our biggest change is in our temporalis and then our masseters as well, as far as eliciting some change. Understanding we can get to the pterygoids and the digastrics a little bit deeper if we don't see our results in these other primary structures. So 3D anatomy. So let's look at our treatment labs here. And let's just get to each one first. The superficial masseter. So I'll pause here. So our for the masseter, our origin is going to be off the zygomatic arch, inserts into the angle and the ramus of the mandible, and its action of elevation, adduction, and protrusion of the mandible. Forgot what it's doing here. So here, ideally, in a side-lying position, needle length is about 2 centimeters. It could be a little less than that. The backdrop will come straight down onto the mandible. The precautions here, the marginal mandibular and buccal branch of the facial nerve. Here we're going to palpate the angle of the mandible, and we're going to needle at 1 finger breadth cranial and 2 finger breadths anterior in a lateral to medial angulation. For the superficial masseter position here, we're going to be in a side-lying position. Needle length will be 2 centimeters with a backdrop down to the mandible. We're going to palpate the angle of the mandible and needle at 1 finger breadth cranial and 2 finger breadths anterior in a lateral to medial angulation. For the deep masseter, we will, again, sideline position, biggest difference. Superficial, we were right about here. For the deep masseter, because it's more cranial, we're going to have to come up a little bit. So our landmark will be off of the zygomatic arch itself, and then we'll drop down a finger breadth from there. For the deep masseter, again, position is going to be sideline. Needle length here is 2 to 3 centimeters, and the backdrop down to the mandible. We're going to needle lateral to medial at 1 finger breadth posterior, 1 finger breadth caudal from the groove of the temporal process of the zygomatic bone, inferior to the zygomatic arch. And then temporalis. For the temporalis, again, we're going to be in the sideline position using a 3 centimeter needle with a backdrop down to the temporal bone. We're going to palpate the temporal border or angle of the zygomatic bone. And we're going to needle 1 finger breadth superior and 1 finger breadth posterior to the angle in a 15-degree superior and posterior angulation. Okay, then onto the lateral pterygoid again. This is going to be in the side lying position. Needle length here is going to need to be a little bit longer so that we can get through that zygomatic arch into that lateral pterygoid. For the lateral pterygoid, position again is going to be side lying with the mouth open 2 to 3 finger breadths. The needle length is going to be 3 to 4 centimeters and there's no backdrop. We're going to palpate the inferior groove of the zygomatic arch. Just inferior to the arch, we're going to needle at the mandibular notch, lateral to medial and perpendicular for the superior head, slightly inferior for the inferior head. It may be necessary to open the mouth to increase the needle window. So then for the medial pterygoid, again, we're still going to be side lying here. This is the one we're going to take this posterior approach. It can be done from a superior through that zygomatic arch. It just is a much more comfortable, convenient, and easy to catch it from the posterior aspect. Right there, that muscle is just sitting there waiting for us. For the medial pterygoid, position again is going to be sideline with the mouth open 2 to 3 finger breadths, 2 potential needle lengths. For the superior, 4 to 5 centimeters, and then for the inferior, 2 to 3 centimeters. Backdrop here is going to be none or the posterior surface of the mandible. From superior, we're going to palpate the inferior groove of the zygomatic arch. Just inferior to the arch, we're going to needle at the mandibular notch, anterior, medial, and inferior towards the rear molars. From the inferior, we're going to palpate the posterior mandibular angle from 1 finger breadth medial, needle slightly lateral and anterior onto the posterior surface of the mandible. Okay, then we'll look at the superior anterior joint capsule, the posterior inferior, and then the articular disc itself. For For the superior anterior joint capsule, again, the sideline position with a 2 to 3 centimeter needle length with a backdrop onto the temporomandibular joint. We're going to palpate along the mandibular arch until you bump into the mandibular condyle. We're going to confirm the location by having the patient open and close the jaw. And we're going to needle half finger breadth anterior and inferior to the condyle in the anteroinferolateral to posterior-superomedial angle to land on the anterior superior joint capsule. Bidirectional, unidirectional rotation would be therapeutic here. Okay, and in order, we'll move on to the articular disc, where we'll identify the anterior border, the posterior border, and then we're just going to have our subject open and close the jaw to identify where the articular disc is, and then we'll just go lateral to medial onto that. For the temporomandibular joint, the articular disc, again, sideline 2 to 3 centimeter needle length, and the backdrop is into the temporomandibular joint. We're going to palpate along the mandibular arch until we bump into the mandibular condyle. Again, confirming location by having the patient open and closing the jaw. We're going to note the anterior and posterior borders of the condyle. We're going to needle lateral to medial at the midpoint of the borders to enter the area of the articular disc. Again, bidirectional or unidirectional rotation would be therapeutic here. We go and lastly here on TMJ, the inferior joint capsule, very similar to our anterior. We're just going to identify that posterior margin. Caution here for the external auditory meatus or our ear. Just going to have to do a great job of palpating for that posterior margin. For the inferior joint capsule, position again sideline using a 2 to 3 centimeter needle with a backdrop onto the temporomandibular joint. We'll palpate along the mandibular arch until we bump into the mandibular condyle. We're going to confirm that location by having the patient open and close the jaw, and then we're going to note the anterior and posterior border of the condyle. We're going to needle lateral to medial at the posterior border of the condyle with a slight anterior angulation to the condyle to land on the posterior inferior joint capsule. Again, bidirectional or unidirectional rotation would be therapeutic here. So one thing I will note on, and we're about to go to the facial muscles themselves. With this particular needle, this is a 1.5 centimeter needle, and you can tell it's a very thin diameter. If you are needling the face, The hand, bottom of the feet as well, but especially the face. The thinner the diameter, the more comfort your patient is going to have. So be kind and find a nice small diameter needle. The face is a nice place for really small diameters there. And then posterior and, well, let's get posterior digastric first. For the posterior digastric, the patient's going to be in the sideline position. Needle length will be 3 centimeters. The backdrop is going to be onto the temporal bone. We're going to palpate the anterior inferior aspect of the mastoid process. We'll needle from that landmark in an anterior inferior lateral to superior posterior medial angulation to land medial to the mastoid process on the temporal bone. And then for the anterior digastric. For the anterior digastric, position is going to be supine. Needle length is only 1.5 centimeters, and there's no backdrop. We're going to palpate the posterior border of the ramus of the mandible. We're going to resist opening the jaw to feel the muscle bellies just lateral from midline. One half finger breadth lateral from midline and 1 finger breadth posterior to the ramus. We're going to needle in an inferior to superior angulation. Okay, now let's move on to the craniofacial region. I'm going to go through, I want to make sure we have plenty of time for the others. And we have a lot of muscles in the craniofacial region. I will probably try to speed this up a little bit. All of these muscle needling videos will be on the student portal. But we want to get through the mylohyoid, the occipitalis, frontalis, zygomaticus major and minor, orbicularis oculi, procerus, depressor corrugator, the levator labii superioris and aliquinase, nasalis, orbicularis oris, rizoris, and buccinator. All are small muscles, technical muscles, muscles of facial expression. Most of these come into play whenever we start looking at Bell's palsy. So I will go through them as rapidly as possible so that we can get to our protocols. Let's see here. So let's get on to our 3D anatomy first. All right. Okay, so here we are for the 3D anatomy of the craniofacial region. Bring these into play. Probably more to do with Bell's palsy, things of that nature. But they can come into play at times with dealing with any sort of a facial nerve problem. There's thought of bringing trigeminal neuralgia into play. Also possibly some of the TMJ pieces. But anyway, we want to look at the different things that we've got here. And we'll just start with the big stuff and start seeing what we've got to work with here. So first off, let's look at the frontalis, or the frontal belly of the occipitofrontalis. Frontalis is the easier way. Its origin, the epicranial aponeurosis. Its insertion is the skin of the eyebrows and the root of the nose. So as we look, there's also on the posterior aspect is the occipitalis. Here, its origin, the superior nuchal line of the occipital bone, inserts into epicranial aponeurosis, which that structure really and truly runs from, let's see if I can get to it. So really attaches all of this across the cranium together as one piece. Different versions of this software, different places show the occipitalis to be a little bit larger. And so this version shows it to have a smaller footprint. Either way, those muscles work to either raise the posterior aspect of the skull or the skin of the skull, and that gets important whenever we start talking about some of our posterior perineural dry needling protocols. But let's take those. I'm going to hide those. Okay, and then there's the visible. Didn't know if that was showing up. Let's see if I can highlight it. The epicranial aponeurosis. So let's go ahead and hide that. Okay, and let's try to hide that again. Okay, uncertain what's going on. We're just going to move on. So let's move to the orbicular muscles. Here, or the orbicularis oculi. Muscles are surrounding the eye. Here, the origin is the nasal part of the frontal bone and the frontal process of the maxilla and the medial palpebral ligament. It inserts into the adjacent muscles around, and its action is just simply closing the eyes. So let's get rid of that, and we're definitely not going to needle there, so we can it's giving me some attitude here. Let's move up into, let's look at the depressor and corrugator supercilii. Here the origin of the depressor is the origin is the frontal process of the maxilla. It inserts in the skin of the eyebrow, and its action is depressing the eyebrows. I'm going to hide that. That brings us to our corrugator supercilii here, medial portion of the superciliary arch, again inserting into the skin of the eyebrow, and it draws the eyebrows infromedially. As we move more medial here, we'll get to the procerus, again, just right here. Its origin is the fascia covering the nasal bone and the lateral nasal cartilage, and it inserts into the skin of the forehead. We move a little bit further distally, we'll get to the different muscles of the nasalis. So there is the transverse part, and then this should be the alar part of the nasalis. Again, any of those muscles that cause that expression, opening, closing of the nares, or dilating the nostrils, is what we're looking at there. So let's move a little bit further to the orbicularis oris. Here, the origin is the modiolus of the angulus oris. It's inserts into the vermilion line and the mandible and the maxilla. And so basically its action is it compresses and protrudes the lips. It's it's the lip muscle. We look a little bit lateral, we'll get to the risorius. Here its origin is the parotid fascia, and then it inserts into the modiolus, the overlying skin of the angle of the mouth. And the action is it pulls the angle of the mouth laterally. So it's got almost a linear pull here. We look a little bit deeper, we'll get to the buccinator. And the buccinator, its origin is the alveolar process of the maxilla and the mandible and the pterygomandibular raphe. It inserts into the angle of the mouth right here, and its action is it compresses the teeth, the cheeks. There was okay, so the buccinator, here's a good reference, compresses the cheeks against the teeth and gum. This action is used when moving food during mastication, also when expelling air from the mouth when playing a wind instrument. So it gives our mouth, our cheek, part of our embouchure, part of our So we get the up here, and we get our tightening of the lateral part of the cheeks through the buccinator. And now on to, we have our zygomaticus major and then minor, more medially. Their origin is off the zygomatic bone, and they insert into the angle of the mouth. The zygomaticus major a little bit further posteriorly than the minor. They both elevate the upper lip. Then we'll move on to the levator labii superioris and the levator labii superioris aliquinesi. The levator labii superioris, its origin is the infraorbital margin. For the aliquinesi, it's just a little bit more closer to the midline than the superioris itself. It inserts in the subcutaneous tissue of the upper lip, and its action is elevating and everting the upper lip. So again, all of these muscles of facial expression, there are a few a little bit smaller. We should didn't bring this into play. Inferiorly, we have the mylohyoid. Its origin is trying to get to it, look through the rib cage. So here we are looking at the inferior aspect of, there we go, at the mylohyoid. Again, the mylohyoid line of the mandible, it inserts into the mylohyoid raphe here and into the body of the hyoid bone. Its action is elevating the floor of the mouth. Okay, so here, all right. So let's look at all of the treatment here. So we'll start with. I know that I've got these. Oh, so fortunately for us this evening, I have not included them in the PowerPoint here. So I will get those included, and they should already be on the student portal. If not, they will be within the next 48 hours. But let's just kind of walk through this a little bit. So for the mylohyoid here, needle length is going to be 2 to 3 centimeters, and the backdrop is either going to be none or the posterior mandibular body at the mylohyoid line. So at the anterior half of the mandible, we're going to go 1 finger breadth posterior, and then medial to the mandible, we're going to needle superiorly and anteriorly towards the posterior mandibular body. So we had anterior digastric right here a little bit earlier. This is just going to be a little bit more lateral, a little bit more posterior. For the mylohyoid, the position of the patient is going to be supine. Here the needle length will be 2 to 3 centimeters. The needle depth is superficial. Backdrop is either none or the posterior mandibular body at the mylohyoid line. So at the anterior 1/2 of the mandible, 1 finger breadth posterior and medial to the mandible will needle superiorly and anteriorly toward the posterior mandibular body. For occipitalis, when we look at this, we're going to palpate the external occipital protuberance. We're going to move 3 finger breadths laterally, 4 finger breadths superiorly, and this is going to be a very oblique angle. We're not going to just drop a needle down onto the skull, but we're going to slide through that tissue from superior to inferior. Again, very superficial. For the occipitalis, the position here is going to be in the prone position. Needle length is going to be 1.5 to 2 centimeters. There's no backdrop. We're going to palpate the external occipital protuberance. Then 3 finger breadths lateral and 4 finger breadths superior will grasp the muscle between the thumb and the index finger to tent the tissue. Then we're going to needle at an oblique angle into the muscle and parallel to the occipital bone. For frontalis, we're going to do basically the same thing. We're going to move, we're going to find the apex of the superior orbit, and then we're going to move 3 finger breadths superior to that. And then we're going to needle again at an oblique angle, almost as a tangent or perpendicular to, not perpendicular, and on a tangent to the skull right there. So very oblique needle there. Biggest caution: don't needle so far that you accidentally needle into the eye. The superior orbit, the apex should prevent that, but keep that needle length a little bit short there. For the frontalis, position here is supine. The needle length is about 1.5 to 2 centimeters. There's no backdrop. From the apex of the superior orbit, we're going to move 3 finger breadths superior. We're going to grasp that muscle between the thumb and the index finger to tent the tissue. And we're going to needle at an oblique angle into the muscle and parallel to the occipital bone. For zygomaticus major, we're going to find the arch of the zygomatic, the inferior border of the zygomatic bone, and then we're going to move 1 finger breadth medially and distally, or 1 finger breadth inferior to the inferior zygomatic angle. Here, you probably won't feel backdrop. Needle is just going to be maybe 1.5 for the zygomatic. For zygomaticus major, position here, the patient can be supine or sideline. The needle length is going to be 1.5 centimeters, and the backdrop there is none. We'll palpate the inferior border of the zygomatic bone, and we're going to note where the bone moves superiorly at the level of the lateral border of the eye. 1 finger breadth caudal to the inferior zygomatic angle will place your needle, and we're going to advance it from anterior to posterior, and the muscle is superficial. Zygomaticus minor, we're going to move just 1 finger breadth more medial to land onto the zygomaticus minor. And again, it's very for zygomaticus minor, position here again either sideline or supine. The needle length will be about 1.5 centimeters, and there's no backdrop. We're going to palpate the inferior border of the zygomatic bone, and we're going to note where the bone moves superiorly at the level of the lateral border of the eye. 1 finger breadth medial to the inferior zygomatic angle, and 1 finger breadth caudal will place the needle and advance in an A to P direction. And again, the muscle is superficial. Very superficial. Orbicularis oculi, we're going to find that the apex of the orbit, and we're going to move 0.5 centimeters further away from that, and that's just to guarantee that we're not entering the orbit itself. For the orbicularis oculi, the position is supine. Needle length is about 1.5 centimeters, and the backdrop is going to be away from the orbital border. And caution here, obviously, to avoid the eyeball. We're going to needle perpendicular to the orbital border of the eyeball, about 0.5 centimeter to 1 centimeter away from the border, most commonly at the superolateral aspect. For the procerus, we are going to, so let me get to the picture. I've included this illustration of all of the facial names that we don't necessarily refer to all the time. But basically, we're going to pinch that procerus together at the upper orbital line using thumb and index finger, and then we're going to needle at an oblique inferior angle from the glabella, which is just this area here, between the eyebrows towards the nasion, which is that groove at the base, at the superior aspect of the nose. So we're just going to very oblique needle. For the procerus, going to be in the supine position. Needle length is going to be 1.5 centimeters with no backdrop. We're going to pinch the muscle together at an upper orbital line using the thumb and index finger, and we're going to needle at an oblique inferior angle from the glabella toward the nasion. There. For the corrugator, do I have, okay, so corrugator and depressor cilii. The depressor is sitting over top, and that's what's faded here. So similar, we're going to find, we're going to pinch the muscle together, the superior and the medial orbital border using the thumb and index finger, and we're going to needle at an oblique inferior and medial angle towards the nasion. So whereas in procerus we came straight down, here we're going to come from a little bit more lateral approach to catch these two muscles themselves. For the corrugator, position again is supine with a 1.5 centimeter needle length with no backdrop. We're going to pinch the muscle together at the superior and medial border using the thumb and index finger, and we're going to needle at an oblique inferior and medial angle towards the nasion. For the levator labii superioris aliquinesi, here at the level of the inferior nasal ala, or ala, we're going to be 1.5 finger breadth lateral, and we're going to needle in an anterior to posterior direction. So we will have backdrop down onto the maxilla here. We'll move a little bit. For the levator labii superioris aliquinesi, the position again is supine with a 1.5 centimeter needle length with a backdrop down to the maxilla. At the level of the inferior nasal ala, 1/2 finger breadth lateral, will needle in an anterior to posterior direction. Further lateral, one full. So for aliquinesi, we were 0.5 finger breadths. For the levator labii, we're going to be 1 full finger breadth lateral. And again, we're going to drop down to the zygomatic, down onto the maxilla as a backdrop. For the levator labii superioris, the supine position with a 1.5 centimeter needle length and the backdrop down to the maxilla. At the level of the inferior nasal ala, 1 finger breadth lateral will needle in an anterior to posterior direction down to the maxilla. So now nasalis, here we're going to be, it's very superficial. We could do it higher on the nasal part of the nasalis, but I choose to do it a little bit lower. It's a little kinder. Again, use as small a diameter needle as you can. But it's 1 to 2 millimeters. We're going to needle distal to the nasal bones, along and perpendicular to the ala, and slightly lateral to the columella. And where did my columella go here? So just superior to the philtrum, we're just going to be slightly lateral to that, right about there. How often clinically do we need to needle that? I'm going to stay away from it on me personally, unless I just really see clinical reasons to do it. For the nasalis, supine position, again, 1.5 centimeter needle length with no backdrop. Here it's a very superficial needle stick. It's 1 to 2 millimeters, and we're going to needle distal to the nasal bones, along and perpendicular to the ala, and slightly lateral to the columella, mid-inferior aspect of the nares. Orbicularis oris, we want to find away from the vermilion border, just away from it just a little bit. And this is obviously a very superficial muscle. For the orbicularis oris, position is going to be supine. Again, a 1.5 centimeter needle length, and a backdrop is none. Here we're going to needle from distal relative to and off the vermilion border. This is a superficial muscle. For the risorius, we're going to move 1 finger breadth lateral from the lateral commissure, or the lateral line of the mouth of the lips. It is superficial, so there will be no For the risorius, the position is going to be supine with the head tilted contralaterally. The needle length is going to be 1.5 centimeters with no backdrop. From the lateral commissure, we're going to move 1 finger breadth posterior and needle perpendicular to the skin. No backdrop. For the buccinator, we're going to come from the lateral commissure. We're going to move 1 finger breadth posterior. We're going to place our index finger in line with the orientation of the teeth. So we'll come in like such, and then we're going to needle perpendicular to the skin, above and below the index finger, perpendicular to the teeth. So we want to make sure we catch that muscle above and below index finger. For the buccinator, the position is going to be supine with the head tilted contralaterally. The needle length will be 1.5 centimeters, and the backdrop here is either none or the maxilla, the mandible. From the lateral commissure, move 2 finger breadths posterior and place your index finger in line with the orientation of the teeth. We're going to needle perpendicular to the skin, above and below the index finger, perpendicular to the skin. Okay, so that basically, again, those videos will be available on the portal. Just for some reason didn't include them in tonight's lecture, but since it's 15 minutes of 8, that probably worked out well. So let's move on to, all right, making sure I didn't need any of these messages. Okay, so on our regional and diagnosis protocols, we're going to look at our suboccipital headache, our migraine protocol, our TMJ dysfunction, our Bell's palsy, our upper trap tension protocol, any of our cervical dysfunction, which includes just almost anything in that region. And then as we start to get closer down to things in the cervical thoracic junction, as we start looking at scapulothoracic and then further distally, we need to look at how can we bring in the CT junction as well. And then lastly, we'll look at torticollis. We don't see it that often, but it is can be an issue that can benefit from dry needling. So what are the regional and diagnosis protocols? So they're designed to be implemented in a layered or a staged approach. Each protocol will contain primary, secondary, and usually there will also be some tertiary dry needling locations. In some protocols, you may also see proximal spinal segmental locations, you might see distal extremity locations, and you may see periepidural locations. So for treatment, you want to start each protocol by treating the primary locations on day 1 of dry needling treatment. If the patient's post-treatment pain improvement is significant, and by that I mean at least greater than 20% improvement, then we want to continue with that treatment, that primary location, and continue with those locations until the patient's pain complaints are either eliminated or they've plateaued. If there is, after using primary locations, if there is no significant change in pain complaint after 2 treatment sessions, then we want to replace the primary locations with the secondary locations. If the patient's post-treatment pain improvement is significant, again, same rule here. If it's greater than 20%, then we want to continue with treatment using those secondary locations and continue with that until the patient's pain complaints are eliminated or they have plateaued. And if there's no significant change in pain complaint after 2 treatment sessions on the secondary, then you want to replace them with the tertiary locations. And again, if you start to see greater than 20% improvement, you continue with those tertiary until pain is gone or complaints have plateaued. If there's still no change in pain complaint, you want to replace tertiary with proximal spinal segmental locations, distal extremity locations, and the periepidural locations in that order. I always like to get my biggest treatment bang for my buck, and I like to do it with my big muscles that are more likely to be in charge of, or my pain exacerbators as I'm moving down the list. Could I come in and could I put 12 to 16 needles of everything that I think would be involved in a patient? I could certainly do that. But it's not necessarily the wisest thing to use more needles if you can get a better response out of fewer. And so the whole purpose behind regional diagnosis protocols is, again, bigger bang for fewer needles. So also remember that research is very strong in reducing pain and dysfunction when combining dry needling with HVLAT thrust manipulation. It's even very good with grade 3, grade 4 joint mobilization. So never be opposed to adding appropriate manual therapy to the treatment approach. They frequently occur simultaneously in clinical practice. One of the very first things that I said when we started out on this journey was dry needling is not a standalone treatment. There's always other things that have to happen. And if I'm working with a patient, I'm just not getting my response that I'm looking for, I definitely need to make sure that I'm throwing in some sort of a hands-on manual approach. In my case, I prefer the HVLAT, but a lower grade mobilization could work as well. So let's look at the different, layers here of suboccipital, of our protocols. First, we'll look at suboccipital headache and migraine. I'm not going to demonstrate all of these. These are things that we've already looked at. For For our primary locations, here we're going to look at our upper traps and then our suboccipitals. As we went through suboccipitals early, we saw that we could hit all of them with 3 different needle locations. And so we'll do that as our primary location. Our secondary location, we would look at the cervical locations that we had from this spinous process of C6 and T4 from the introductory, the thing that we did in the lab. And then we also want to throw the levator scap in. So for my suboccipital headache, that would be my secondary locations. Our tertiary locations would come more anteriorly, catch our SCM, our sternocleidomastoid, and then we want to also get this lateral piece as far as our middle and posterior scalenes. So with my headache, my suboccipital, I definitely wouldn't start with this challenging stuff to the lateral piece. I would definitely start with the most common, that upper trap, that suboccipital stuff. Move into the spine itself, catch those in our secondary, and then tertiary, catch these more challenging things. When we get to the perineural protocols, we'll see that there are some things that we could add to this depending on where the location of the headache is, but we'll look at that when we get to the perineural in just a moment. For TMJ, our primary locations, and we discussed, one is going to be temporalis. We want to needle that, and then superficial and deep masseter. Most of the time with our TMJ or a TMD, this is where we're going to get our biggest response. If we're not getting the response there, then we move on to our secondary locations, our lateral and medial pterygoid, our deeper structures, or our anterior and posterior digastric. If finally we're still not getting that and we still are getting this pain, then we will finally go after our anterior joint capsule, inferior joint capsule, and the articular disc. Most of the times we can elicit a change in our bigger muscles first and avoid needling into those structures. These do tend to be a little bit more uncomfortable needling into that. So go after that primary location first. There are some exercises that I've included in here that can be beneficial that have to do with our depression, our elevation, our lateral deviation, protrusion, and retrusion. Definitely if we're dealing with a temporomandibular joint or temporomandibular dysfunction problem, you definitely want to get some passive range of motion, some active range of motion, and then progress them onto some resistive range of motion. These will be included in here, and any of that can be Googled. There's lots of good information about exercises for the jaw out there. A little beyond the scope of this course, but for our needling locations, big stuff, and then the smaller, and then finally the joint itself. So for Bell's palsy, first, we want to catch the primary muscles that lift and move the lips. And that's going to be the levator labii superioris, the zygomaticus major and minor, and the risorius. So those will all lift, elevate, and laterally pull the mouth. Secondarily, we want to move to the levator labii superioris aliquinesi, and then we want to get to the muscle of the orbicularis oculi and the frontalis. So first, we're going to move that mouth up. Second, we're going to lift the eyes and the forehead up. And then finally, in our tertiary locations, we'll get the corrugator and the depressor here, and the procerus between the eyes, and then the buccinator. Locations 1 and 2 probably give us our biggest movement, most notable. Probably won't see as much change, visible change out of our tertiary locations, but if we're making some good headway here, I'd definitely move in there and get the rest of that happening. Finally here, we can catch the periepidural locations of the facial nerve, which we'll look at when we look at our nerves momentarily, but we can hit the 3 branches of the nerve on the mandible itself and the superficial masseter. We can catch that nerve up a little bit higher in the temporalis. And then as it comes between the ear and the mandible itself. And so really our goal is just to stimulate that nerve, increase the excitatory responses from the nerve out to the muscle. See if we can make some changes there. Not a whole lot of research yet on Bell's palsy. Anecdotally, I've seen good responses from dry needling for Bell's palsy. And again, there's also an exercise prescription that I've included in here. Again, a little bit beyond the scope of this course, but this comes from WebMD, some really good exercises to include if you are treating Bell's palsy. They start with a little warm-up, work on some exercises for the cheeks and the nose, and then move to the mouth, including your lips and your tongue, and then finally some eye exercises. So one of our bread and butter regional diagnosis protocols for the cervical spine is our upper traps, our tension. Most people in clinic have this problem, whether it's patients or staff. And so for here, our primary location's just going to be these upper traps. So typically we'll hit the upper trap one spot right in the middle, but there are technically, if we look at trigger points, there are two identifiable or identified trigger points according to the big red books. One a little bit more lateral towards the acromion, and then one a little bit more proximal. So if I'm dealing with tension, I probably will take one lateral and one a little bit more medial for my upper trap, get a little bit better bang for my buck. Then I'm going to move to Levator Scap. I want to hit that thing because we will, if we're holding for having a tension issue, then that scapula is going to be elevated. We are going to have a lot of tension in that, so we need to hit that as well. And then finally, we will come back and hit these three places from our introductory needling of the cervical spine. I just say the HMDN one, that's the in-person variety of the course. But it's the spinous process of C6, but definitely also do it at T4 as well. I didn't have it listed here, but definitely hit T4 as well to get all of that cervical musculature. For our cervical dysfunction, our primary locations, again, that spinous process of C6 and T4. May as well hit them bilaterally unless you just absolutely have a unilateral problem going on. And this dysfunction, this can be almost anything in that cervical upper thoracic spine. Our secondary locations, we want to hit the upper traps. We want to hit the semispinalis capitis at the occipital insertion. So it's going to come up here and we want to catch it over here. We want to catch interspinalis at C7T1. And then we can hit segmentally at the spinous processes of C4 at T1, and then any other locations that are needed. Any of that deep paravertebral musculature can be needled next to the spinous processes. Lastly, we'll move on to our tertiary locations. Here we're talking about our levator scap, our splenius cervicis, longissimus cervicis, and our middle and posterior scalene. So here we're talking about this articular pillar business. Again, it's definitely not what I would hit first, but as a tertiary, I would come back, catch levator, and then catch this lateral business as well. But again, always would start up with our, where did we go? Our spinous process of C6 and T4. At the CT junction, we're moving a little bit further distally now. Hard to deal with a cervical spine if you don't acknowledge that the thoracic and scapular piece comes into play. Here, our primary locations would be the upper traps and then our spinous process, C6, T4. Secondary locations, I would put in the middle traps, which we'll get to in our thoracic course, which is in, or lecture, which is in 2 weeks. Our middle traps, and then segmentally anywhere C5 all the way down to T6. Here would actually throw in, we've got levator scap and then rhomboid minor. So we'll want to catch all of the area right here. And then finally, our tertiary locations, our lower traps, which again, we'll get to next lecture. Serratus superior posterior, which is right here. And then rhomboid major, serratus anterior, and then subscapularis, which will catch all of these underneath on the anterior aspect of the scapula. And then torticollis, for torticollis, what we'd look at, obviously first we'd look at the sternocleidomastoid. I mean, we talked a little bit earlier about how to pull that away from the body, from the neck, to stay away from the jugulars. So that would be position number one. Number two would go ahead and catch the scalenes. Probably less of a player, more so with SEM. But in case we do need and don't get the response from SEM, we can definitely get into the scalenes to make our change there. And if we're going to get there, tertiary, let's go ahead and get levator scap. Probably not as involved as SEM, but if we don't get the response, then we can get to those. Okay, so we're almost there. We've got 4 nerves to get through, and then we're done. So why perineural protocols? Here we're going to look at the greater and lesser occipital nerves, the great auricular nerve, and then the facial nerve. The first 3 more sensory from the ear posterior, and then the facial more of a motor. So with the greater occipital nerve, you can see that it's going to innervate the area right about here, superior to the greater occipital protuberance. For the for the lesser occipital, it's going to be this area between the occipitalis and the ear itself. We'll get to the great auricular, which will be inferior up to and including the ear. We'll see parts of it onto the jaw itself. And again, the facial is going to be more of motor for the face. So for the greater occipital nerve, we see it here. Several areas of entrapment of the occipital nerve, where the greater occipital nerve emerges from the C2 dorsal root ganglia, also between the atlas and the axis, between the inferior oblique and the semispinalis capitis muscle, and then finally where the nerve pierces the semispinalis capitis. And so we know this nerve comes out right here. So our needling locations are primary at the occipitalis. Move up here, which just away from the midline. The second is going to be 1 thumb breadth lateral from the external occipital protuberance. So we're going to have our primary right here. Our secondary we're going to have in the obliquus capitis inferior and semispinalis capitis. So this muscle is going to continue to be very tight. This is one of our big headache muscles, quite honestly, semispinalis capitis. And then we also want to be able to hit upper trapezius. I mean, all of that attaches right there. So let's catch the upper traps. Because of it, where the nerve originates, we can always hit the spinal segmental away from spinous process of C2. And so for sensory problems, headache on this posterior aspect, greater occipital nerve is a great nerve to work out. For the lesser occipital nerve, let's say that pain is a little bit more not in midline, it's more midway between the ear and the posterior. The lesser occipital nerve may be to blame. Here, area of entrapment is the splenius capitis and the sternocleidomastoid. So we look at our needling here. First on the posterior mastoid at the SCM insertion. And then we're going to want to go 3 finger breadth superior and 1 finger breadth posterior. And that is going to be on an oblique angle. So it's going to be laying next up to the skin on that. We also can come down, because this is where they get entrapped. We can needle into splenius capitis and then the SCM itself. If we want to look at our proximal spinal segmental locations, we can catch it at C2 as well, down to the lamina there. But again, this is for sensory changes that we're seeing posterior to the ear. Back a little bit further. The great auricular was going to have a little bit of a footprint right in this area. We talked about it having a little bit. Well, let's come back. The great auricular, its area is right here. So here, our primary neural location, again, would be on the mastoid process. It's going to be superior and inferior aspects of the posterior mandible. So we'll also catch, again, anteriorly, we'll catch here and here on the mandible. And then we're going to have, so we had one on the mastoid process. We're going to have another that's going to be 1 finger breadth or less than 1 finger breadth posterior to the ear. And again, this is going to be in an oblique angle. This one's going to just lie next to the skull underneath the skin. So those right there. And then lastly, we can get into the SCM. Needle length on most of these is going to be very shallow, 3 centimeters. It could probably be much less than that. Because of its innervation, where this nerve comes from, we could also do needling the spinal segments at C2 and C3. And then finally, for the facial nerve. Let's see. So the facial nerve exits the posterior cranial fossa through the internal acoustic meatus to the facial canal, which is going to be right in here. Sensory fibers supply the anterior 2/3 of the tongue and the skin of the external auditory meatus. It also supplies the muscles of facial expression. So facial nerve, I'd target this, again, dealing with Bell's palsy, some sort of a facial issue. We look at that there. So our primary locations, less than 1 finger breadth distal to the external auditory meatus. Here, needle length is going to be 2 centimeters or less. So just posterior to the ramus of the mandible. We're gonna needle into there. At the inferior angle of the posterior mandible, the midpoint of the masseter. Where's my thing? Midpoint of the masseter, and then the posterior superior aspect of the zygomatic arch. So 4 nice little locations right here. Secondary, we can hit the muscles of facial expression. We know where they all are. If we want to go hit some of those, the zygomaticus, the aliquinese, the levator labii, any of those, the rhizorius, buccinator, that are innervated by the facial nerve, we can needle those as well and stimulate that as well as the facial nerve to try to get a better response from there. So it is 8:06. We've lasted a little over 2 hours. So I will have all of this content uploaded into the student portal. Hopefully today is Monday. Hopefully within 48 hours. What our next lecture is going to be on the advanced thoracic spine. But your homework is to submit a sample 3KS 3D kinetic screen video that includes both the cervical linear motion, 5 repetitions there, a cervical diagonal rotation, again, looking up over the left shoulder, down over behind the right elbow. We're going to do that 5 repetitions. We're going to repeat it each side. So up over the right shoulder, down over the left, behind the left elbow. And then we want to do trunk rotation, 5 repetitions, really wind it up. So it can be a video of you, it can be a video of somebody that you've roped into the project, and then just a brief description of what your analysis is of what you're seeing on that cervical screen. Work on those, submit that through the portal when you get a chance, or on the dry needling arena, and then we will see you in 2 weeks for the advanced thoracic.